Hello, the title of this presentation is The Influence of Social Determinants of Health on Emergency Department Visits is Mediated by Illness Severity. My name is Melissa McCarthy and I'm a professor in the Department of Health Policy and Management at the George Washington University School of Public Health. I would like to acknowledge the contributions of my co-authors on this slide and state that none of us have any financial disclosures to report. The study results today are based on a project funded by the National Institute of Minority Health and Health Disparities. For the last several years, we have been conducting a prospective cohort study that is examining the relationship between social determinants of health and healthcare use. Today, I'm going to talk specifically about the relationship between social determinants and ED visits. During a 15-month period beginning in September of 2017, we enrolled adults insured by the District of Columbia Medicaid program in a study at the time of a healthcare visit they had. Patients who consented agreed to complete an interview during their visit and to also complete 2 telephone follow-up interviews 6 and 12 months later. In addition, they also consented to allow us to obtain a copy of their Medicaid claims data for 2 years prior to study enrollment as well as 18 months post. Today I'm going to show you the results of interview data that we collected at the time of study enrollment and their Medicaid claims data that occurred before up to 2 years prior to study enrollment. The study is guided by the WHO model of social determinants of health. This model emphasizes the importance of public policies and their impact on a person's socioeconomic position in society. These structural determinants of health, education, occupation, income cause intermediary social determinants. These intermediary determinants of health are material circumstances, our health behaviors, and psychosocial factors. They are the proximal causes of illness and injury. Guided by the WHO framework, we included in our interviews questions about structural and intermediary social determinants as depicted in this slide. We used the Medicaid claims data to measure healthcare use. A little bit about our sample. We enrolled 8,943 adults. Most of them, 82%, had been enrolled in the Medicaid program for the full 24 months prior to study enrollment. The sample is 2/3 female. It's largely Black. Many have completed high school and about half are working. As you can see, they also report a number of different social adversities. Because we measured a lot of different social determinants of health, many of them are correlated with each other. So rather than examine the relationship between each individual social determinant of health factor and ED visits, we group participants into together when they had a similar social risk profile. We took 19 of the social determinants of health we measured and we identified participants that had similar responses using a statistical technique called latent class analysis. This slide shows the 4 distinct social risk groups identified by latent class analysis. The first is the top green box with the green line. The top box with the green line, it's the group with the least social adversities. 43% of our sample are in this group. They are most likely to report living with children and the least likely to report a variety of the other social risk factors. Participants that were grouped into group 2 are reporting, they're about 20% of our sample, and they're more likely to report financial strain. Participants in group 3 represent 27% of the sample. They are likely to report no access to internet at home, not having access to a car to get to medical appointments. There's high smoking and unemployment rate. Finally, the most severe group, class 4 at the bottom, it represents 9% of the sample, and they have just a variety of a prevalence of high social risk adversities. So we use these 4 social risk classes to look at the relationship between social determinants and ED visits. We use the Medicaid claims data to identify all ED visits, both discharged and admitted, that occurred in our sample. And we also use the Minnesota algorithm to distinguish between an ED visit either as primary care treatable versus ED care needed. We identified over 57,000 ED visits among our almost 9,000 participants over the 2-year period. 29% of the ED visits were classified as primary care treatable, and 71% were classified as ED care needed. This box plot shows the relationship between our social risk class and both the mean and median number of ED visits. As you can see, the little diamonds are the mean, and as you can see, the average number of ED visits rises as the social risk class are more severe. An important factor to include when examining the relationship between social determinants of health and ED visits is illness severity. We relied on the risk adjustment measure called the Chronic Disability Payment System to account for how sick each participant in our sample is. The CDPS identifies medical conditions in the claims data and computes a score based on the cost typically associated with different medical conditions. The higher the CDPS score, the sicker the patient is. And as you can see from our slide, as the CDPS quartile gets higher, more representing sicker people, the primary care treatable and ED care visit average number of visits rises. There's a nice dose-response relationship. Next, we modeled the total number of PCT and ED care needed visits separately as a function of the 4 social risk classes, age and gender, using generalized linear mixed effects models. This table shows you the log relative rate of ED visits for the higher social risk class compared to the lowest, adjusted for age and gender in the first column, and then adjusted for the CDPS and selected medical conditions in the other columns further to the right. For example, in the column labeled no CDPS, the social risk group 2 has a 13% higher rate of primary care treatable visits relative social risk group 1. Social risk groups 2 and 3 have a 37% and 59% higher rate of PCT visits relative to participants in group 1. Notice that the relative ED visit rates are even higher by each social risk class for the ED care needed visits. In the next column over, we adjust for illness severity by including the CDPS score, and you notice that the effect of the social risk classes on both PCT and ED care needed visits is lower than when you don't adjust for it, but still significant. You'll also notice that when you look at specific conditions such as diabetes, cardiovascular diseases, renal, and such, the influence of the social risk classes on the PCT visits and the ED care needed visits is similar, meaning there's no interaction effect between social risk class and the type of health condition a person has on the ED visit rate. Because the relative rate of ED visits was reduced when we adjusted for illness severity, it suggests that some of the influence of social determinants of health is mediated through illness severity. We estimated the mediating effect by comparing models that included and excluded the CDPS, and by calculating the difference using a bootstrapped method. As you see in this slide, illness severity mediates approximately 1/3 to 1/2 of the influence of social determinants on primary care treatable visits, and for ED care needed visits, it's even greater. The mediating effect is between 2/3 and almost 90%. In conclusion, these results show that social determinants of health are associated with increased ED visits of both types. When you control for illness severity, the impact of social determinants on the number of ED visits is smaller, but still a significant effect. What this means is that some of the impact of social determinants of health on ED visits is because social determinants of health cause incidence of disease, and disease in turn causes ED visits. But it does not explain all of the effect. There is still residual impact of social determinants of health on ED visits that's not explained by the presence of disease. All in all, we conclude that social determinants of health have a large impact on ED visits. A good percentage of this effect is through health conditions that people have from living with adverse social risks, and the rest is through the social determinants of health themselves. Thank you very much.